What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. We're back for another solo episode, Brett. And so we said we were going to do more of these, and damn it, we're sticking to it. So last week, if you didn't catch it, Michael Shacklock was just amazing. So by the time this comes out, too, we'll have announced we got a course coming up with him this year. We're so excited. He's on a quick trip to America, and we were lucky enough we kind of snagged him. So he's going to be teaching an upper and lower basic course here in Troy. That's kind of a hybrid model. So it's going to go. You're going to get access to the online stuff, but then you're also going to get access to him live and in person, which is pretty damn rare in today's day and age. So
yeah, it's going to be awesome.
And seeing him live is it's special. You know, it's like being around. We talked about being around people like Pavel, being around people, like Herbauis of the MBT world and stuff like that. Michael is in another class.
Yeah, I agree.
100%. So anyway, today's episode. So we're going to talk about the functional triage, Brett. And I'm giving you credit here. You're kind of the first person in the world that I heard this term from. I know it's not an original term to you, but it's something that you've been talking about for a long time. And so it's something that we've kind of based Gestalt on, honestly, which is integration, functional triage. Can you talk us through like what is functional integration or functional triage and kind of where it kind of plays into what we're doing?
Yeah, I think, originally this being, over 20 years ago, the model was a lot more simple, actually, because there was basically three things. For us it was active release technique, it was MPI, and it was traditional rehab. And it was basically a game to see, who could do the best job of mixing and matching those three things together. And at the time, that was producing the best results. And then over the last 20 years, a lot of things have evolved, and we've learned a lot more about soft tissue techniques. We've definitely learned a lot more about what's happening with manipulation, how to palpate for it, how to be better at that skill. The world of rehabilitation, back then DNS didn't even exist. So DNS is now, in my opinion, and we're homers for it, but I think it's the most powerful rehabilitation technique that exists. So basically what we're left with being able to kind of borrow and steal from all these different things to get our best results. So in any model, like when we're trying to talk about getting the best results, obviously, you could know all these different techniques, and that would be saying something to know them all. But the real power is knowing when to use what tool at the exact right time, and that is what is basically missing. So there's not that many people in the world that are actually capable of doing that well. Mm-hmm. And what's hard is because you're fresh off a seminar and you're wanting to utilize this information. But not every case requires every single one of these tools. That's the hard part. So being able to time these cases out, knowing what to use at what time, that continues to be the missing link. And I think that's basically the struggle, not only for the students, but for chiros, for physical therapists, for ATCs, for everyone who's seen patients. They really struggle in their ability to do this well.
Yeah, I 100% agree. And, if you're listening but not watching, so if you're on YouTube, you can see it over behind our shoulders. It's kind of our functional triage. And, we always have referenced the core four a lot in these episodes. And our core four are there for a reason. And one, they're all four assessments. And two, each one of these has its own unique piece in the puzzle. So neurodynamics, we talked about that last week, is up on this screen because there's a patient tomorrow, even today, as we're seeing patients that may not get better if we don't fully understand that technique. And then to take it to the next level is something that we've really tried to do within ourselves and within these walls at Winchester Spine and Sport, is not to bastardize the information too, to truly understand it completely and then know when to integrate it slowly but surely. No different than if we are in an ER setting, right? Like, the story that you've told, and you know, I've stolen it from you, is if you walk into the local emergency room and you've got chest pain, they're not just going to throw antacid, nitroglycerin, and a muscle relaxer down your throat, right? I hope not, anyways. It would be up to the triage nurse to basically decide, are you having a heart attack, or do you have some indigestion that's causing your chest pain, or maybe you do just have some tightness in the muscle surrounding that, or, you know, whatever it might be. But if you don't have that first initial step, then you're kind of screwed, because then you're just always behind the 8 ball of chasing what actually is going on.
Yeah, and actually we had a lockout for our last staff meeting, but one of my good buddies, he's in charge of all the emergency rooms in the Mercy system, and he said something really fascinating to me a couple of years ago. He said, you know, if you were to get into a horrific car accident, and, you know, even though like they win awards for how good their system is, he said whether or not you live or not is probably dependent on who the attending physician is that night. And I really was kind of taken back, because I really kind of felt that, you know, at this point, that in a hospital system, it would be systemized enough to where, you know, it wouldn't be that way. But he said it's just like anything else in life. And I mean, these are like such critical decisions that get made like in a second. And if they make the wrong one, then, you know, it could mean death for you or for somebody else. So in our world, it's not life or death, but it's kind of the same principles of knowing like when to do what at the right time. And, you know, we a lot of times even compare it to sports. And, you know, it's what made Wayne Gretzky great. You know, last night, I'm sure everybody, or hopefully you saw the special on Derek Jeter. I watched it for the second time today. I just thought it was really fascinating because these really good athletes too. What they're really good at is situational IQ, which is basically the same thing. So you and I aren't necessarily athletes anymore, but we're still needing to, you know, make decisions throughout our day that determine our results. And I think a real important point, you know, like Sully's a great example. You know, like it's not just sports too. If Sully doesn't know how to, you know, land an airplane on the Hudson, then everyone on board that plane dies that day. So it's not only just in the sports world, it's life in general. And if you hang around humans long enough, you'll see that not everybody's going to be perfect all the time, but the best in the world, I think they're able to just continuously make good decisions. And then I would say the other thing, when they maybe they're off track a little bit, they're really good at knowing they're off track, and then they can kind of correct it. It's like someone who's learning how to swing a golf club well. Like, they'll know when they get off plane, and they can like almost subconsciously get back on plane, where the rest of us, you know, we really struggle with that. So being able to do that throughout your day, I think, is a huge determining factor. I would just say that we're all basically seeing the same patients, whether you're in Lincoln, Nebraska, whether you're in Los Angeles, whether you're in New York, Sydney. We all see the same people. You know, like they have different names, but they have different Earth costumes, as we say. But anyways, we're all seeing the same cases. So to kind of pick through and see like who's doing the best job, and it's not always like we talk about here. It's not always that you think you got them better in 2 visits. It's about how well did you actually manage their case? How much better is that really difficult case where you've improved their quality of life? We're honestly getting that patient better in 2 or 3 visits. It's not even possible. So what are the metrics to know whether or not you did a good job? And those are sometimes intangibles, but especially when you start seeing really difficult cases. I mean, you obviously you got to be in these people's lives to change the quality of their life. So it's not about getting everyone better in 2 to 3 visits. I think that's like one of the biggest misconceptions that are out there. Like when you first start off and you're seeing a bunch of acute pain, yes, you know, you got miracle after miracle because they're essentially derangements, and you know we adjust them and they do great. That's, you know, the low-hanging fruit. And then you have all this complexity with these other problems in the chronic pain world. And there's 2 ways to get to chronic pain. You get to chronic pain by, you know, having 3 autoimmune diseases. Maybe, unfortunately, you've been abused. Like, there's all kinds of things to get there in that category. But then you also you just haven't had great treatment, you know. So it's hard to find, you know, people out there like our listeners that are, you know, giving a world-class treatment. That way you really know whether or not somebody needs the next more invasive procedure.
Right. What about, Brett? You've been doing this for a little bit. You've been around the block. When you kind of said something earlier about when you get off track, the best in the world are able to kind of get there quicker than maybe other people won't. What, in your experience, is the best way to kind of feel like you're out of there? Is it more just intuition, or is it just seeing things? Like, where in your day are you kind of finding those realizations?
I think it depends on like what category we're talking about. If we're talking, let's just talk about manipulation for a second. Like, one of the benefits of paying attention, having experience is, like, now at this point, like, I can get, for example, a seated CT move set up, and I just know by setting it up that's not the way to do it, you know? So then you have 10 other ways that you can do it. I think, like, experience kind of helps you there to kind of know, like, for example, not to thrust on something that you know you're not going to have success with. That way you don't make yourself look foolish and you don't hurt your patient. In the rehab world, I would say your audits aren't changing. You know, we talked about that, I think, our last podcast, where, you know, it depends on what your audits are. For us, our audits are tension tone, trigger points, joint blockage. Maybe it's neurologic, like deep tendon reflexes or joint blockage, whatever it might be. But whatever you decide are your audits, your technique should be addressing those. And if they're not addressing those, then you need to, either you're not good at your techniques, or your techniques need to be questioned a little bit, you know?
Sure.
So, absolutely. And that's where, like, you know, we always get in the debate of, you know, how we got to this point. I'll be perfectly clear, like, we're not saying that all the other ones aren't good. I mean, you could definitely, someone else could step in here and put ART in their core 4. The only reason our core 4 is you correctly alluded to, is because they're not only a treatment, they're also like a system for assessment. So not that ART or some of the other ones wouldn't be, but I think these other ones are a little bit more like pillars as far as that goes. And then, but I want to understate the other ones that are up there, because I mean, we are using all of these to help our patient on a daily basis.
Right.
Yeah.
And I think this is somewhat of an older one. This is my functional triage slide. It's a little bit different than Brett's, honestly, and that's kind of a fun evolution for both of us. But, you know, fascial manipulation isn't up there yet, but it's going to be.
Oh, yeah.
I mean, it's definitely playing a role, and we've been using it a lot lately. And so, but yeah, I think, and then the next step of that is understanding that not all of these are together in treatment.
Right.
So just because they're in our toolbox, it doesn't mean that every single visit you're pulling out every single one of these tools, right? And so understanding when and where to do what, I think, is then the next kind of evolution of a clinician, and something that I've been really trying really hard on myself, of really trying to hone those down. And I think something that I've maybe gotten from you too is that a lot of times less is more in this world, especially in treatment. Doesn't matter, you know, if you're, I think a good example is a low back derangement. You know, when I first started, I had the urge to not only manipulate them, find a directional preference, stick some needles in them, scrape on them, DNS, tape them, you know, like do all these things. And now, I mean, anymore, as my schedule fills up and I have less, you know, wiggle room with patients, a good adjustment and a directional treatment is a great way to start day one.
The case when I was young that would have taken 2 hours literally for me to get out of my office is now my easiest case. Because usually, I mean, if you got carried in because your low back is in such poor shape, we know it's probably discogenic pain. We know they're probably going to have a directional preference. They probably need a direction to be manipulated in. Well, now you're looking at 5 minutes of treatment and basically education, you know? So, I mean, it's kind of funny how the case that you think is going to take forever actually does not. So I wanted to add another thing, and I think this never gets talked about, but to be a great clinician, you got to have good clinical reasoning skills. And I feel like I'm on a huge evolution for myself on that. I feel like I really was a product of having a good memory, being able to memorize stuff, and that's like what the American school system basically rewards you for. And then there's another thing, which being a good clinician, which is critical thinking. So memorization, which is all of chiropractic school, and critical thinking could not be more on opposite ends of the continuum that exists. I'm not saying there's not a benefit to having a good memory, but I am saying that, like, learning how to critically think well, and what critical thinking actually is I mean, we have like our decisions that are so easy for us to make during the day. Mm-hmm. But then you have those decisions where like the reason it's a hard decision is because you could almost argue it either way. Mm-hmm. And critical thinking is really about like taking everything into consideration and making a decision based on the information that you gathered when it's not so binary. Mm-hmm. And I think that's like never talked about, but all day long we see it on the athletic field, but we call it something different. But throughout the day, I think the greats, they'll just continue to, take in the information, not get bogged down by noise that the patient's saying, knowing what's pertinent, what's not, still being empathetic and, then thinking you're listening to them, but also then like knowing no matter what the patient is trying to bully you on, knowing what you need to do and sticking it through. And then patients are so smart, like it's almost like a test. Like they're kind of bullying you on purpose to see if you're going to stand your gun. And I mean, at that point, then we're back to, certainty, confidence, never cockiness. And these are all like hallmarks for what makes for like the best clinicians in the world. Never talked about because you think that if you get good at all this stuff that you're going to be great. And I mean, that's half of the battle, but I'm serious. The other half is management of difficult people. And the better you get at this, you're going to be seeing so much difficult stuff. And, being able to deal with them, like when they start to push back on you or bully you or, they come back and they're not better, so what do we say to them to keep them on board and be a cheerleader for them in their journey?
We always joke too, our interns are lucky to be with us for extended periods of time, and they see the best, the worst, and everything in between, we always joke, sometimes we'll have a shadow come through and you're like, man, that was a bad day for a shadow to be here, because they'll leave going, holy shit. Because you look horrible. Yeah, they didn't help anybody. But these cases are so, it's just not miracle after miracle. I mean, yes, like we were talking in the acute cases, we can get a lot of miracles and et cetera, but being able to, like you said, keep people on board enough to be there. And I just released a reel from our 2 episodes ago when we were talking about intangibles of keeping people on board is an essential part of making sure that these techniques work too. Like if you can't come back and re-audit the function, then you're lost. You really don't know whether or not they're getting better.
Well, every case, and we talked about this before, worth repeating. You have your miracle. We've all been there. You walk into a room, you do some intervention, and it's just literally life-changing for the patient. And then you have, on the other end of the continuum, you have like orthopedic intervention, which would be surgery. And then you have everything else in between. And I would just make an argument to say that most chiropractors are really, really struggling, especially the evidence-based group, with that. We call them this black hole of patients here, because they basically need to be kept on board as your changing function. Mm-hmm. So and what it really comes down to, Taylor, is basically a lack of confrontation, is what because basically they need something. So what do you need to say to get them on board? And that comes down to being able to confront a person to say, this is what you actually need. Now, keep in mind, every single one of our patients, mine included, they want to be better in one visit, and they don't want to pay for that one visit. Right. So you're up against that. So of course they want to be out of here in one visit. Yeah, it's like saying I want my teeth to be straight after having my braces on for a day. Someone's got to be there to explain what this takes, because as we all know, like if you don't educate the patient well, it's not really on them because they don't know any better. You'll know by if everybody's canceling because they're out of pain. That's how we always kind of judge.
Yep. Yeah. I think too, and a way to get better at it. I'm lucky. We're in group practice here, and so we get to hear stories, and we'll make fun of the other docs when they say something stupid.
The walls are thin.
Yep. Yeah. But I think if you're by yourself and you're like, well, how in the hell am I going to get better at this? I think it's just like you got to take leaps of faith, and if it doesn't work out, then you got to be able to learn from those situations and think, okay, go home with your schedule from that day and say, man, oh man, Nancy, I flubbed that up. I need to figure out a way to reword that. Or like, dang, that worked really good with this patient. I need to try it with this patient. And just like, if you don't take the time to think through those little intricacies, especially, as you're getting your practice rolling, then I think you're missing out on such a big chance to get better. It's easy for us to go to a seminar and get better at manipulation or manual therapy, but to get better at your confrontation, like you're talking about, you just gotta try stuff out. And we kind of talked about it 2 episodes ago of find your shtick. Whatever you're good at, your personality, then you gotta lean on that. You're never gonna be good as Brett or me or anyone else in this world as far as personality. But if you can double down on what you're really good at personality wise, and then mix it with being amazing at these manual techniques, the rest is history. I mean, people are going to be knocking down your door to come see you.
Yeah, I think too. I mean, preparing for not just like what you're going to be doing with them with the different techniques, but also preparing. When you walk into a room and you already kind of know that the case isn't going great, so almost like rehearsing in your mind what you need to say to them when it's not going the way that we want. And I think people don't think about that, but like that way you're not walking in a room and just getting so shocked by it. Before you walk in, just consider what all your possibilities are. And usually you kind of have a hunch how a case is going, and and then, like as you said, you said something, you didn't like the way it came out. So the next time you run into something similar, you change it. And then at that point, I mean, you're basically, you're rehearsing for all the different scenarios, and then it gets a little bit easier because I mean there's not 100 of them. I mean if there's 10 or 20 of them where you gotta give them some little speech about why they need to be changing function and not be so concerned about pain, and you're doing well when everyone's on board. You're gonna lose I had to fire one a couple weeks ago.
Yeah,
you're gonna lose some people along the way, but by and large, I mean, it's like Mark King and I used to always say, and Corey Campbell also, it's like literally just tell them what they need, walk out of the room. Like it's I know that's, but for the young clinician, I think that's easy. Just say it and walk out because no one's gonna dig their heels in.
Twice a week for 3 weeks.
Yeah, start there.
Start there. That's a great start. I do want to ask you, Brett. So. Let's just talk, like kind of finish here with the manual technique. So the question we always get, and I kind of have my own answer, but I'm curious on yours, is of these things here, where would you start? You're a Tri-2 student, let's say, or let's do 2 scenarios. You're a Tri-2 student, and then you're also, let's say, 4 or 5 years out of school, and you're realizing that you maybe need some help with your technique.
Right. Well, I think like on the manual side of things, first of all, whether you want to admit it or not, most of us are chiropractors, not all of us, but so we'll talk to the chiropractor side of things first. If people have a preconceived notion of what their service they're going to get when they go to the chiropractor, and yet you're unable to deliver this, then that becomes a problem. And Lynn Fay used to tell me, he said, if you can get really good at palpating and adjusting, they'll be on board for, he said, all your weird DNS stuff or whatever, reflex locomotion. But there is some truth to that. So as long as you can give them in a way what they're needing, and I mean, you're hard pressed to find somebody who doesn't have some joint blockage throughout their body, and I mean, this goes against other people's philosophies, which I understand, but we're a little bit different, I guess, in the official MDT principles, which is they use a regression of force. And if I was Robin McKenzie, I would, and you're teaching to a bunch of people who don't know manual therapy or don't know how to manipulate, then you're just basically building safety in, which makes a lot of sense. But we've all been trained on how to do it. So we actually, we've earned the right, I guess, to like through joint play, and like we can maybe, this is just theory, you could possibly get there quicker if you're able to put motion into a joint that for a fact is stiff. Or actually, like we'll put people in the MDT hospital just on our palpation, not that we moved a joint 200 times in a certain direction. Instead, like we palpate someone's CT junction, we're like, wow, this is really stiff. We use maybe in-range techniques to manipulate them there, and then we're sending them home with repetitive in-range in the motion that joint's going. And if you think about it, what a marriage MDT and MPI have. So when you're young, the other component to being young is you're trying to practice everything. So you're gonna definitely over manipulate, over treat, over mobilize when you're young, and then as you get older, you realize what a powerful tool that is. And it was said to me once, and I think this is a great analogy. The best acupuncturist in the world needs one needle. everyone else is putting 50 needles in, right. That's a tall tale, but you get the point. Like simplicity, there's a lot of genius in simplicity. I'd say that.
For sure. I think just to answer my own question too would be, if you're a student, MPI is where you'd start. I mean, a Chiro student, it's where you'd start, and then I think from there you would bridge out to MDT and DNS, and then from there you can start adding in these ancillary things. But I think if all you knew was MDT, manipulation or motion palpation, DNS, holy smokes. And then once you add in neurodynamics, I mean, now you're a force to really be reckoned with. And then it makes ART more powerful. It makes everything else in your tool bag so much more powerful. And then
the other thing I'd add to that, like if you want to be good at adjusting, you have to understand functional anatomy. So I think a mistake gets made with a lot of the young students. They want to get, it's kind of, they have it backwards. They actually get good at the psychomotor skill of adjusting somewhat. They suck at palpation. They know nothing about anatomy. So what I would much rather have people do, and this is the path that I kind of went on, was, if you played sports and you're young, usually adjusting kind of comes naturally. But I needed to learn how to get way better at palpation when I was young, and then quite honestly, and I was good at this part, but like you got to spend some time, you got to do some book work. Newman's kinesiology book. We were looking this morning at Dave McGee's orthopedic book. Like those are great starting places to kind of. I mean, if you don't know what you're feeling and you don't understand how joints move or their architecture, good luck trying to feel it or adjust it. So
got to visualize it first.
Yeah,
right? Awesome. Great conversation. I think you just got to start somewhere. I get emails all the time from Gestalt of like, hey, I've been out 10 years. I don't know where to begin. Where should I start? Just start. Just start somewhere. Like if DNS intrigues you, come to a DNS course. It doesn't matter if you start on the exercise track or the AA track. Like you just got to start somewhere. And so, and then from there, if it piques your interest more, then go to more, and then start asking more questions and start applying it little by little. And
more on the microscopic level, I would say, because the question's always, everyone's got big dreams about what they want to be. They want to work with a college, they want to work with a professional team, they want to do all these things, but they haven't. You got to start with the person who's in front of you right now. So you get really good at that 8-year-old kid who's playing baseball there, and when you've mastered that, then So I think to that point too, is as far as being a better clinician, the only thing you got is a patient that's in front of you right now. So do a great job there.
Absolutely. Beautiful. All right, guys. Thanks for tuning in. As always, any questions, any comments, any topics you guys want us to talk about, please let us know. And check out our upcoming courses. We got some really good ones coming up. And stay tuned for more awesome podcasts. And we'll talk to you guys soon. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.